Alrighty, good morning everyone. My name is Sidney Schuttrow. I am the State SHIP Volunteer Program Coordinator for Tennessee SHIP, and thank you for attending today's webinar for the Part A and B update, the Part D enrollment outcomes update, and an open enrollment review that I hope to have quite a bit of volunteer participation, so you can tell me some of the good news stories, some things that are that we might have to do better in the future. So it's going to be a good open format, and I hope we get a lot of participation. So what we're going to start off with today is some A and B updates to make sure that everyone knows some of the updates that we found out during or after open enrollment, so everybody's on the same page with all the updates for 2018. So to start, we're going to talk about the Part A as in Apple, or your hospital insurance premium and deductibles. We do have some changes. So many of us know, if you've ever been to one of our trainings, most beneficiaries across the country have premium-free Part A because they've paid 40 quarters or more, or the equivalent of 10 years, and paid into the Medicare tax or the FICA tax. So those beneficiaries get a premium-free Part A. For beneficiaries who have not worked their full 40 quarters, they do have a premium for their Medicare Part A. In 2018, those premiums have increased. So they've increased to $232 for people who have 30 to 39 quarters, compared to the $227 it was in 2017. If you have 30 quarters or less, your 2018 premium is going to be $422 a month, which is different than $413 in 2017. So those premiums did increase. We also have an increase in our Medicare Part A deductible for our hospital insurance. It went up to $1,340 compared to the $1,316 it was in 2017. So we did have a slight increase there as well. Alrighty, any questions on the Part A premium or the Part A deductible? Great. So we are going to move to the Part A hospital stay benefit period. So when you're on original Medicare and you're in for a hospital stay, days 1 through 60 is that Part A deductible of the $1,340 in 2018 compared to the $1,316 in 2017 that we just talked about. If you're in the hospital for longer than 60 days, days 61 through 90 has increased to $335 per day for days 61 through 90 compared to $329 it was in 2017. Days 91 through 150 has increased to $670 per day compared to the $658 it was in 2017. So we have increases across the board for this aspect of our Medicare Part A benefit period cost. Any questions on those? And if you're,
these are still warm.
if you are asking a question and I'm not able to hear you, it might be because I have you on mute, because we do have some background noise that I'm trying to take care of as we're going through. Carol Samuels has her hand up, and I believe that's because she can't hear, and I'm not sure how to help you at the moment. Or Carol, do you have a question? Okay. So we're going to move on to the next one. So for our Part A cost for our skilled nursing facility benefit. Now remember, skilled nursing is not long-term care. This is not a stay at a nursing home. This is a short-term stay at a rehab facility. So maybe you fell and broke your hip and you need some rehab for speech, physical, or occupational therapy. Getting some rehab for that hip. Just like last year, days 1 through 20 are free. So you get the first 20 days in your skilled nursing facility at no cost. Days 21 through 100, however, has increased from 2017 by $3. So we went up to $167.50 in 2018 compared to the $164.50 it was in 2017. After days 100, the beneficiary is responsible for all the costs for that skilled nursing stay. Okay. Those are all of our Part A cost updates. Does anyone have any questions on Part A before we get into Medicare Part B updates? And again, if you're asking a question and I can't hear you, I've probably muted you for background noise issues. So also feel free to use the chat box and chat in any questions that you have if that's easier for you to keep the flow of the webinar going. Alrighty, so Medicare Part B premium and deductible update. It's taken a couple years, but we finally have a Part B premium that is for everyone across the board, no matter when they enrolled into Medicare. So in 2018, everyone will be paying $134 for their Medicare Part B premium. Now, there are some exceptions to that rule. If you qualify for assistance to pay for your premium, of course you're paying nothing. Or if you have a higher income, which we're going to talk about, the IRMA increases, you may have a higher Medicare premium. But for those individuals who pay a premium, $134 is going to be the base premium for 2018. In 2017 and even in 2016 before that, we had kind of a range of premiums that beneficiaries could have, mainly because there was no cost of living adjustments or a COLA increase in 2016. So some people got to keep higher premiums while new beneficiaries coming into Medicare got higher premiums. So luckily, we have no range of premiums that we have to worry about this year. The base premium, like I mentioned, in 2018 has stayed at that $134, which was the highest premium last year. You can also notice on the webinar, if you're able to view, our Part B as in boy deductible has also stayed the same at $183. So there has been no increases necessarily to the base amount of the premium and deductibles for Medicare Part B in 2018. Those have stayed consistent. Speaking of the IRMA increase, and when I say IRMA, that means the income-related monthly adjustment amount. So we call her IRMA for short. This is when beneficiaries have a higher Medicare premium because they have a higher income 2 years prior. So before I get into that, we did have an inbox question of if their COLA didn't allow them to afford the full $134. And that's a great question. From what my understanding is of why there is a base of $134 is that the increase that the beneficiary received based on their COLA would allow all Medicare beneficiaries to get that $134. So I know we can elaborate many, many different scenarios of why this beneficiary can't and this beneficiary can. I'm not getting into all of those individual scenarios because there's a lot of different factors to that. But the cost of living adjustment for 2018 should have given everyone who was not able to get an increase in their premium in the past to meet that $134 base premium. Good question. So how IRMA works is Social Security looks 2 years back on your tax return. So we're in 2018 now. So Social Security is going to look back at your 2016 tax return to determine your income that year and if you are going to get an income-related monthly adjustment amount. So if you are single and you file individually and you make less than $85,000 in 2016, or if you're a married couple and you've made less than $170,000 in 2016, you're paying that $134 base premium. Again, we're not talking about the assistance programs that help pay for that. We're just talking about if you make below that, that's your premium. We'll get into assistance programs in March. We're not going to touch on those today. If you make above $185,000 up to $107,000 as an individual, or $170,000 to $214,000 as a married couple, you can see your premium increases to $187.50. And just so you know, people who are viewing the webinar, I know you can read, and I'm not trying to insult you by reading the slides to you, but we do have some call-in users who aren't able to see the screen and may not have the resources and materials that I sent them. So that's why I'm giving a lot of detail that you can see on the screen. And I apologize, I am one of those people who hate when presenters read off the screen, and I know that's exactly what I'm doing, so I apologize for that. But I want to make sure everyone has all the information who's in attendance. For individuals who make $107,000 to $160,000 in 2016, or married couples who make $214,000 to $320,000 in 2016, their premiums will increase to $267.90. $160,000 to $214,000 for individuals, and $320,000 to $428,000 for married couples will increase to $348.30. And anyone above $214,000 for an individual or above $428,000 for a married couple will pay $428.60 a month in their Medicare Part B premium. So you can see as your income increases, so does your Medicare Part B premium. Now there are two ways that a beneficiary can adjust that back down to around the $134 mark. All beneficiaries are able to appeal through Social Security if they deem that due to circumstances beyond their control, they retired or something happened and their income dropped dramatically from 2016 to 2018, they might be able to appeal to get that lowered premium, or eventually the premiums may even out for beneficiaries. So if you retired in 2018 and are only making $80,000 compared to making $214,000 as the highest sales rep in your company, you may, let's see, so in 2018, look at 2016, 2019, they'll look at your 2017 tax return. So in 2020, Social Security will look back at your 2018 tax return and your premiums may even out. So there are two ways that that can happen. Any questions on IRMA? All righty. Moving right along. So we talked about these increases or these updates during update trainings and on a webinar last year, but I'm going to do a quick update for C and D since we talked about A and B. We got to finish our alphabet. In 2018, our Part D deductible has gone up to $405 compared to $400 in 2017. And the donut hole or the coverage gap prices has also increased. So when I think of the donut hole, and the easiest way that I've learned to explain it to volunteers and beneficiaries, so we're not getting through all the complicated stuff, is think of it as the full cost of your medication. Don't think about what the insurance company pays and what you pay. To make it a clearer picture, think of the full cost of the medication. When that reaches $3,750 in 2018, the beneficiary will fall into the donut hole or the coverage gap. When they're in the donut hole or the coverage gap, they're responsible for 35% of their brand name medications and 44% of their generic medication costs. So kind of like our roller coaster, you have your deductible, you go down through your copays, and then you're back up again, potentially at a higher cost when you're in the donut hole. Now to get out of the donut hole or the coverage gap, your $3,750, again, full cost of your medication, has to increase to $7,508.75. When that happens, the beneficiary is out of the donut hole or the coverage gap, and they're in what's called catastrophic coverage, where they're responsible for the equivalent of 5% of the cost of their medication. And with that, I believe Sandra Smith has a question. So I'm going to pause and see if Sandra has a question, and it can be about anything. I might have missed your hand. Sorry, Sandra.
Hi, Sidney. This is Adrienne. I'm sitting with Sandra. I had a question about the IRMA.
Yes.
So for couples, what if they either file singly or if they're not living together but not yet divorced?
If they're filing individually, it would go into the individual tax return. So they would be under those income guidelines.
Okay.
Only if they filed jointly as a married couple would it increase to the middle column.
Okay, thank you.
You're welcome. Good question. Okay. All righty. So that was the donut hole. Any questions on the donut hole or anything we've talked about so far? Yes, Linda Johnson.
Yes. On the tip sheet where it talks about Part B, it says that your Medicare Part B premium may be higher than $104.90 a month. Did the $104.90 a month go away entirely? And is that a misprint?
Yes, on the tip sheet that is a misprint, and I will go back and I will update and edit that. But it should, the $104.90 should be $134. Thank you, Linda.
Thank you.
Mm-hmm. And we're going to talk about the tip sheet that Linda was referring to here after the presentation. So I will see where that error is, and I will correct it accordingly. And thank you again for sharing that, Linda. I appreciate it. All righty. So we're also going to talk about, this is the only part of extra help and assistance we're going to talk about today, and that is the extra help copay. So again, we talked about this last year before open enrollment, but just as a refresher, and many of you saw all of this firsthand during open enrollment last year. For extra help, if you qualify, your generic copays are going to increase to $3.35 compared to $3.30 last year. And your brand names are going to increase to $8.35 compared to the $8.25 it was last year. So we got a nickel and a dime increase. But as we know with our low-income beneficiaries, nickels and dimes are a lot of money to them. Also, our Part D premium benchmark in Tennessee has decreased. So the Part D benchmark is important for two reasons. The first reason that pertains to extra help is that is how much money a beneficiary is allowed toward their Medicare Part D as in drug premium each month. So think of it kind of as a premium stipend, so to speak. So they get $30.62 a month toward their Part D premium, which for I believe it's 6 or 7 plans in Tennessee gets beneficiaries a premium-free drug plan. On the flip side of that, the Part D benchmark is important for kind of a negative reason as well. For our beneficiaries who are assessed a prescription drug plan or Part D penalty for not enrolling into a drug plan when they were first eligible and did not have any other credible coverage, they're assessed a 1% for every month they were eligible but did not enroll penalty. And that penalty is based on the $30.62 a month premium benchmark in Tennessee. So for those people who had a penalty, they get a lower penalty than what they did last year because our benchmark has decreased from $31.76 in 2017 down to the $30.62 in 2018. Any questions on that? That's a lot more information than what's on the slide. So if you have any questions, don't hesitate to either type it in the chat box or feel free to ask. Okay. We do not have the new Extra Help and Medicare Savings Program income and resource guidelines for 2018 yet. We will get those probably in February or March of this year. So please mark on your calendars the third Thursday of March for the SHIPSMP Volunteer Update webinar series because we will be discussing Extra Help, Medicare Savings Programs, TennCare renewal packets, and some things like that that have been asked to cover based on surveys from last year's webinar series. So mark your calendars for March to get some updates on that when we get them. Little cliffhanger, here's to come. Just like your Medicare Part B as in boy, Medicare Part D as in drug also has an IRMA, or an income-related monthly adjustment amount, IRMA for short. Again, Social Security looks back 2 years on your tax return. So in 2018, we're looking at in 2018, we're looking at your 2016 tax return. And different income guidelines apply. So just because we just talked about Medicare Part B, some of the incomes are different when it comes to drug plans. So $85,000 or less for an individual and $170,000 or less for a married couple, you're paying that plan's premium. Again, we're not including the people who qualify for extra help right now. Those people may have the premium free like we talked about. Right now we're assuming everyone's got a premium for the sake of this conversation. Anyone single between $85,000 and $107,000, or married couples between $170,000 to $214,000 will have an increase of $13 plus their plan's premium based on the IRMA. So for example, we have, can't remember if it's this year or if it was last year, all my years are running together, we had a $17 a month premium at one point. So if I made over $85,000 as a single individual, I would have $13 more added on to my $17 a month premium, which would get me a $30 total a month premium. We did have a question come into the chat box. Are these based on gross incomes or net incomes after tax deduction? This is based on your modified adjusted gross income. So it is before deduction is what they look at for this, the IRMA in both Medicare Part B and Medicare Part D. So great question. Thank you for submitting that. If you make, for a single individual, $107,000 to $133,500, or a married couple, $114,000. Sorry about that. $114,000 to $267,000, your premium is going to increase by $33.60. An individual, $133,500 to $160,000, or an married couple, $267,000 to $320,000, it's going to increase you by $54.20 plus your plan premium. And above $160,000 for an individual and above $320,000 for a married couple, you're looking at a $74.80 a month premium increase from your current plan's premium. And again, same rules apply. You can appeal it, or in 2 years the premium is going to even itself out, just like we talked about with Medicare Part B. Questions on that? Let's see if any. See, I had it. Peggy Ransom, I've unmuted you. Do you have a question, Peggy?
Yes. Does this apply to Part C also?
Yes, this does apply to Medicare Part D and a Medicare Advantage plan if it has a drug premium.
Right. Okay.
Thank you. Great question. Sandra, did you all have another question as well?
Not right now. Thank you.
You're welcome. And Carol Samuels, did you have a question? Your hand is raised. Just want to double check and make sure. All righty, moving right along. So that was all of the updates for A, B, C, and D. So we're done with updates unless anyone has any additional questions. All righty. Now we're going to touch on our Medicare Part D enrollment outcomes. And what we did, many of you attended update trainings before open enrollment, and we talked about a new pilot project. Ooh, we got somebody's phone ringing. If you could put your phone on mute, please. And I'm not able to mute that person, and I don't know why. Okay, sorry. So Tennessee, along with 10 other states, are participating in this pilot project to track the amount of money that SHIP kind of, sort of, in a roundabout way saves Medicare beneficiaries when we change their prescription drug plan or their Medicare Advantage plan. We're not calling them savings, however. We are calling them outcomes for enrollment. So I'm going to give an example, but during open enrollment, someone came to you, enrolled into, for just an example, this is not a real scenario, just an example, SilverScript Choice, and their cost was $1,500 for the year in 2018. You did a comparison on Plan Finder, and you were able to find a plan for $700 for 2018. Well, we are tracking that $800 difference as an outcome for us enrolling that beneficiary into a new plan that helps save them money. So that's kind of the premise of our Part D enrollment outcomes. This is really to help demonstrate the services that we do. We have a lot of data of how many people we talk to, what we talk to them about, but we've never really gotten, before this pilot project and the year before we kind of did a small pilot, we've never been able to demonstrate to elected officials our true impact in terms of financial impact, which is what a lot of people like to see. Now, our goal is to demonstrate the work that we do, not to have a high dollar amount of outcomes. That's not the purpose. We're not compared to these other 10 states that are in the pilot project to see if we save people the most money in our outcomes. That's not the goal of this. It's really just to show elected officials right now, because we are having funding issues, that, hey, we're doing great work and you need to keep us around so we can help beneficiaries locally in our community. And we're worth the money that you're giving to us in our grant to keep this work going. So like I said, we're tracking the before and after costs of any drug plan and Medicare Advantage plan. So it's not specific just to Part D plans. We're also looking at Advantage plans as well. All the data is compiled and entered directly into our database, ShipTalk. Some of you may have access to ShipTalk. Others of you may just report your data to your coordinator, and the coordinator puts the data into ShipTalk. Either way is great, but that's how we're compiling everything, and we're able to run reports and see how much money agencies, our state, individuals, we can run all sorts of numbers to see the outcome. I do really, really want to stress to staff and volunteers who are on the webinar today that this project is all year round. This is not just for open enrollment. So if you have enrollments in January, we're still looking at the before and the after costs based on the Medicare.gov Plan Finder. So don't stop reporting that data to us. We still need it to go all year round. I'm not going to go into more specific examples of this is how you find the data, this is how you report the data. If you want more information on that, please go to our Tennessee SHIPSMP YouTube channel and look at the September 2017 webinar. I have the link down there on the page, and it's also in the attachments that I emailed. Click that link, go to about the 30-minute mark in the middle of the presentation, and that's going to talk you through how to record and how to get that data to report to your volunteer coordinators. So I'm not going to talk about that today, but you do have a resource that's on that YouTube channel. Any questions about why we're doing the enrollment outcome project? Because I have some great numbers to share with you. I'm so excited. Okay. So we started this pilot project in July of 2017. So we didn't really get volunteers necessarily on board or trained until right before open enrollment because now the data is required in our database. But our total from July 2017 to present, January 2018, and not all data is confirmed. We're still getting more and more data in every day. But drum roll, oops, wrong way. $8,559,467 and counting. thank you, thank you, thank you to everyone who has participated in this pilot project, staff, volunteers. We could not do any of this without all of you. Last year, we did a small pilot with a few of our agencies and some volunteers. We had $3.5 million just during open enrollment. We have increased that by $5 million in, what is that, 6-month period, and not even all the data has officially been entered yet. So we are doing amazing, and we can show our funders, the Administration for Community Living, and all of our elected officials this great data. And it shows that we are paying for ourselves in terms of funding. We get a little over $1 million every year to fund our programs, and we have $8.5 million in outcomes. So we are paying for our program almost 8 times what we're funded for. So this is great information to share. Feel free, if you're wanting to contact your elected officials about the importance of SHIP, feel free to use this data as well if you'd like to. I know we have. So any comments, questions, yays, anything? Woohoo. I just remembered I'm being recorded, so I sound silly. That's good. All righty. So if there's no further questions on that stuff, we're moving right along. And I'm, oops, gosh darn it, sorry. I keep hitting the wrong computer screen. I want to get some feedback from all of you. So this is where if I do have you muted, you're probably going to have to raise your hand so that way I can hear you, or you can type your comments in the comment box. But what we're going to talk about is the 2017 Open Enrollment Review. I want to talk about good, better, and best. Last year we did the good, the bad, and the ugly, and I realized that was very negative. We only had 1 opportunity to share good stuff and 2 opportunities to share bad stuff. So this year I want to do 2 opportunities to talk about the good things and only 1 opportunity not to talk about the bad things, but to talk about things that we can do better. So when we think about good, I want you to think about some good news stories that you can share with the group. When we think about better, what can we do better next year? Whether that be you personally, assisting beneficiaries with comparisons, whether that be staff, and how they can assist you better in volunteering during open enrollment. And then the last thing I want to talk about is what was the best part of open enrollment and what you feel was the best thing that you were a part of during the 45 crazy days that we affectionately call open enrollment. So let's start with good news stories. Who wants to share a good news story with the group about what happened during this open enrollment period, meaning between October 15th and December 7th of 2017? Again, if you're talking, you're probably going to have to raise your hand because you might be muted. Oh, I think Peggy wants to talk. Oh, Peggy, do you have a story to share? I saw you on the speaker. I wasn't sure.
No.
Okay. Darn. That and I called you out, sorry. Come on, this isn't a shy group. Or maybe we are a shy group today. Well, of course, one of the good news stories that we have up here at the Commission on Aging and Disability is the savings across the state that we just talked about. But we also had a very effective intern who came to us from Belmont University, who did a lot of presentations and a lot of outreach during open enrollment for us. So that was a really good news story for us. And a lot of our agency staff really pitched in to help us do comparisons and data entry, and I don't know if we would have survived if it wasn't for the help of our volunteers up here, and I know the staff at the local levels will be able to echo my same appreciation to all of you who helped during open enrollment. We would not be able to have survived if it wasn't for the help of our volunteers. I have a feeling everyone's waiting to tell me the bad stuff. I don't want to hear. Anybody else want to share?
Sidney.
Yes. Who's this?
Yeah, this is Alice.
Alice, yes. Do share.
Yes. So I had a really, really great experience. I was talking with a lady whose husband had just retired from U of M, and they were East Indian. And so we did a phone consultation, and she kept saying, I'm sure I don't understand this because I'm not American. And I was able to tell her, trust me, that is not why you don't understand this. It has nothing to do with your nationality. Medicare is hard to understand. But we were able to go through it. When we got through, she totally understood. She just loved, she said, the explanation, how it, I was hopefully able to make it so simple. We were able to save them quite a bit of money. I don't remember exactly, but we were able to save her husband quite a bit of money. She just turned 65 in December, and she's going to wait until, this month, and she's going to call me back, and we'll enroll her. But she was just ecstatic because she felt so lost, and she just felt like it made a difference, and she was able to see some savings.
Excellent. Thank you so much for sharing, Alice. Just helping I know what I do, and it's not an easy task, and I'm sure Alice will agree with me, is trying to make Medicare simple. It's a very complex system, and I try not to use a lot of the Medicare jargon that everyone likes to use, but definitely keeping it simple and getting the beneficiary to understand. Excellent work, Alice. I'm so glad, and thank you for sharing that story. We did have a couple stories come in via the chat box, so I do want to share those with you, and I am going to name the people because they deserve the praise for their good news stories. So Carol Samuel helped a person change who had been on the same plan that she started with on Part D, came to her and saved that beneficiary $60 a month in their drug costs. So $60 a month times 12, I got to do math because I can't do that in my head right now. $720 for the year. That's groceries. That's electric bills. That's Christmas presents. That's so much that we probably don't even realize for our beneficiaries that can help them do so many things. Thank you for sharing, Carol. Let's see. Glenda Temple said, just seeing how excited the participants became when I showed them that they can get their prescription costs per month for a lesser amount and their monthly premium lowered. They just have no idea it can be lowered, and they are prepared for the cost that always goes up. That's an excellent story. I know a lot of us have the clients who come to us and say, I've never changed since Part D started back in 2006. I've had the same plan. I love the company. I know I'm going to, just like Glenda said, I know the increase is coming. I just prepare for it. Well, why do you have to prepare for an increase when there's more cost-effective options out there for you? So thank you for sharing, Glenda. I know we all have very similar stories to that. And excellent work. Anybody else? I think all the good news stories are probably something very similar. So I really appreciate you all sharing. Now for what might cause some more discussion. What could have gone better for open enrollment? And please try not to say Medicare.gov Plan Finder working better. We don't have any control over that. I'm not really looking for that necessarily. We know there are glitches every year. It crashes probably December 7th of every year just with overflow of people trying to enroll at the last minute. So those are things that we always talk to CMS about and let them know, hey, the system's down, hey, this isn't working. So we do our best that if there is an issue and we hear about it, that we report those issues. So anything other than kind of issues with Plan Finder, what could we have done better during open enrollment last year? And I love constructive criticism, so please feel free. If I've done something that I can do better, or staff, I will relay the message and We all want to hear from you all of what we can do better to help you have a worthwhile volunteer experience. Oh, Columbus.
Yeah.
Yeah, go ahead, Columbus. I've unmuted you.
There's one thing that I think, from what I've come across over this long period of time, is that somehow if we could get through to the children and grandchildren, what is taking place, because as I find, what I do is I go around to a lot of churches and, make pitches and do little short talks to the congregations, and then the adults, those who are seniors, don't quite understand it, which, for a long time I didn't understand most of it, and some of it now I don't. But the children, 35, 40-year-old group, need to somehow be brought into the loop, whether they can further explain it, or maybe on a daily basis, as on visits to the parents' home, about the SHIP program.
Absolutely, yeah, targeting pre-Medicare beneficiaries and caretaker relatives of Medicare beneficiaries. Excellent idea, Columbus. I've definitely written that down, and I'm going to share that with our staff across the state. I think that's an excellent idea. All righty, let's see. I have Dolores Walker. I have I'm trying to unmute you, Dolores. It's not letting me unmute you, Dolores. Dolores, I will come back to you once I figure out how to unmute you. Linda Johnson, I have unmuted you. What can we do better, Linda?
Yeah, the facility that we used is a shared facility with other Tennessee departments, and so they had a main receptionist, and I was there to greet the people, but they would always go to the main receptionist first, and sometimes there would be a line and they would stand in line, and then I would go tell them that I could help them. But if there was some way that we could figure out how to tell them, that they don't have to go to that main receptionist first, that might be a better way to handle it.
Okay. Sorry, I'm writing notes now. Yeah, so maybe having more signage that, SHIP, if you want SHIP, come here, instead of waiting in the line at the front desk, who will most likely, with all of our partners are great, will most likely tell the beneficiary, oh, you need to go see her at that table. But if we had more signage or something along those lines, it would be easier for the beneficiary to get to you without having to wait in that line. Excellent. Linda, thank you so much. Who else do we have here? Sandra, I think your hand's up, but I'm not sure if that's from earlier.
It is, but actually do have a comment.
Sure.
I think one thing that we could do better is better outreach to diverse communities, and especially some of our, I'm not sure exactly how we would wrangle the ESL communities, but that's definitely something we need to do. So maybe just better spreading out into different communities.
Absolutely. And for those of you, I'm terrible with acronyms, but ESL is English as a Second Language. And I agree 1,000% with reaching out to more diverse communities. That's actually one of our performance goals this year for the SHIP program through our grant, is to reach out to more limited English speaking, or limited English proficiency is what they refer to it as, throughout the state. Absolutely. We had a better suggestion come in on the chat box from Glenda, perhaps more PSAs sent to newspapers, radio stations, nonprofits, hospitals, physicians, clinics, churches, etc., alerting everyone to the possibility of saving money on Part D plans. Absolutely 1,000% agree with that. I think now, especially with our Part D outcomes pilot, we're actually going to be able to do a better average cost of savings that we give our beneficiaries. So we might even be able to say, utilizing free SHIP services may help you save an average of 1,500, whatever it turns out to be, during open enrollment, and we would kind of dissect our data just for open enrollment numbers. Excellent suggestion, Glenda. I will pass that along to the staff as well. Anybody else? Dolores, I'm still trying to unmute you, and I can't. So I'm not sure what's going on, or if you... Oh, you're unmuted. Dolores, did you have something we could do better or a good news story? I see your hands up. You might not have anything to say.
Can you hear me? Can you now?
Yes, I can hear you now.
Okay. Well, this is kind of like, well, I'm not going to say it's necessarily a good news story, but what I found helpful when we have participants who come in continuously each year to have their plan reviewed, when we have saved the information, then it moves pretty expeditiously, because all we have to do is review the medicine and the dosage that they are taking now, and don't have to always put those drugs in. We may have to take out some that they are no longer using. So that I found that to be time saving.
Absolutely, and I think that is something definitely that fits into both the good news category and something that we can do better, is giving those people the hey, you know, we saved you money this year. Please come back next year, or we'll put you on an email or mailing list to make sure that you know what's coming up for appointments or events next year, so we can do this for you again. So yeah, absolutely, Dolores. I will pass that along to everybody. And we are going to have a staff spring training coming up in March, so I'm going to save all of these ideas and all of these stories that you all have shared and share that with our staff, both in an email by the end of the week next week at the latest, and at our spring training as well. We had a couple more come in on the chat box. So Joanne Lord said it helps in the rural communities for them to know who it is they're going to talk to, as many have been in for many years. Absolutely. So if you're willing and you're going to continue to volunteer with SHIP, which we hope everybody does, hey, next year when you want to come and get your plan compared, come see me. My name is Sidney Schuttrow. My name is Joanne Lord. Come back and see me. Ask for me. I'm familiar with your case. People like to see familiar faces. I agree 100%, Joanne, if you're comfortable with that. I know staff do that a lot, but I mean, we're here what seems like 24/7. I'm sure some of the staff can relate to that. So if you're a volunteer that's comfortable with people coming back to you on a regular basis, like Dolores mentioned, it does make the process smoother. You have all that information already uploaded. You just have to do little tweaks here and there. So absolutely, Joanne, thank you very much. We also had one come in from Alice. Is there a way for the state level to contact medical offices to encourage them for more participation? Several beneficiaries receive very incorrect information from their doctor's office. We can definitely look into reaching out to doctor's offices to educate on our services and how we're non-biased and how we can help them. Absolutely. Let's see.
Sydney, hey, this is Alice.
Yes.
I wanted to add to that, and I
Sure.
say reaching out from the state level because we need more credible. I think it would be more credible. A lot of them don't take us seriously.
Mm-hmm.
And a lot of the doctor's offices come across as, well, we already know what to do because they're in that mode, but they're not in the position to keep getting all the changes.
Right.
So a lot of my beneficiaries were giving me information. Well, my doctor said, that I'll never go in the donut hole. Yeah, well, that's not true. So,
Okay. Yeah, I'm definitely writing all this down, and I'll talk to my director, Shannon Jones, and our quality assurance and program development coordinator, Ryan Ramsey, to see if we want to do and how we could do a state outreach to some local doctors' offices to educate them about our program, for sure. Anybody else? See, I knew we'd get more talkative as we talk about things we can do better, which is not a bad thing.
This is Kathy from Murray County.
Yes.
And I have a question about, we tell people do not give your Social Security number over the telephone. And I know that they're going to be changing them starting in April, but there will be many who still have their Social Security number. How can we let them know that we are not trying to steal their identity? Because often,
yeah. I'm sorry, go ahead.
Oftentimes, people will not be able to go to the senior center and they want to do it over the phone, so I do it from home. But I started doing it from the senior center because I can have them look the senior center up in the telephone book and call the senior center and find out that I am who I say I am.
Right. I know what we do a lot here at the state office is to remind them that, because we don't do cold calls, so we're not just finding people who are 65 and older and just calling them out of the blue. So
they
we
forget that they've called.
Right, exactly, yeah. So, and a lot of our beneficiaries forget that they called us, or they've called so many places that they can't remember that they called SHIP. But definitely saying, hey, I'm returning a call from you from last week or whatever, in terms of your Medicare question. I'm with SHIP. We're a free, non-biased counseling service funded by the federal government, or well, really funded by the government, state and federal. So that might help ease them into, we're just here to help. And of course, if they're adamant, I will not give out my Social Security or my Medicare number, kudos to them for one, because that is good. We talk with SHIPSMP, and Lonnie will give some information about the new Medicare cards and some scams and things that are going on in February, which we'll talk about here in a minute. Lonnie, I know you're on. If you could maybe for your webinar also put in some tips and tricks of how to get volunteers and staff to make sure the beneficiary knows that we're not, those scammers, just like Kathy's been talking about, and how we can make the beneficiary more comfortable. Because, I mean, one of the things we do with SHIPSMP is say never give out your Medicare number. But what's the first thing that a SHIP counselor really asks for if we need to do a comparison? Your Medicare number. So I don't know if that answers your question fully, Kathy, or gives you some tips and tricks. Anybody else have any suggestions for Kathy on how to make beneficiaries more comfortable? Okay. We had a couple more suggestions come in, or comments come in the inbox. So Suzanne Hunsacker said, when I was talking with people, some would see what they could save, but then say they would tell her, my insurance person tells me I shouldn't change anything, so they leave even though I've shown them the difference. That's probably one of the hardest things about being a SHIP staff person and volunteer, is remember, we're non-biased. So even though we see and we know in our gut and our heart of hearts that we can save this person hypothetically $1,000, but they say, I really like my insurance company. They've never steered me wrong. I can talk to them and maybe get their prices down, or I can talk with my doctor and get on a new medicine. So our job is to give them the most up-to-date, non-biased information so they can make an educated decision on their health care. And if they take our advice, excellent. If not, I'm sure Susan can agree with me that, or Suzanne, can agree with me that sometimes it's frustrating that we want to help people, but they have, and we can't force it. So thank you for sharing that. And Carol says, more needs to be done to make them aware of the differences between Part D and Part C. They get so much in the mail and at the pharmacies to enroll into Part C and don't understand the differences. Absolutely 1,000% true. We all know Medicare beneficiaries' most common misconception is a Medicare Advantage plan is the same thing as a supplemental plan. And all of us who go through our training know that is the complete opposite of the truth. Supplemental plans are not Advantage plans. So I will look into finding some good resources and maybe some good handouts and good information that really describes the differences between Part D and Part C that we might be able to use during the year, and maybe during open enrollment next year for volunteers and staff to have on hand in case people are getting more confused. We have a good visual or some good information on the differences. And Lonnie Hitchcock, our SMP coordinator, is encouraging everyone to look at the SMP Resource Center, which we can all log into, and I believe Lonnie approves users, as some good resources for this type of information. Also the SHIPS TA Center, which if you register to be a user on that, it's got some great resources, that our director, Shannon Jones, can approve you as a user. So we have, and I will make a note to put those websites and those links in our follow-up email to everyone who attended. That way you all can get your information and get logged in for those resources. Is that okay? Everybody would wants me to send those out? I think it would be good for everybody to have. Anything else that we could do better?
Hey, Sidney?
Yes.
Can you hear me?
Yep.
Okay. I just want to say that in those resource centers, all of the SHIPs, like in all the other states, have submitted resources into these resource centers. So, I mean, there's maybe something that's already done out there that you might be able to find, like for a presentation or, you know, anything like that. It could already be done, or you could add to it or anything like that. Because if I actually are going to do a presentation or a PowerPoint or anything like that, I look at those resource centers first before I ever start anything. And then I can get ideas or use something that's already done. So anything like that, it's a very good resource to use.
Absolutely. Thank you, Lonnie. Yes, it is a national resource center. So anybody from anywhere in the U.S. States and territories will have resources that we can share, use, manipulate to make it Tennessee specific or whatever we need to do. So thank you, Lonnie. I appreciate you adding that information. All righty. Last call. We'll do. And if you don't want to share what we can do better, please feel free to send me an individual email and let me know your thoughts or any good news stories or anything you thought was the best that you're not comfortable with sharing with the group. Please feel free to shoot me an email individually. I'd love to have all of your feedback so we can make recruit more volunteers. Yes, absolutely. To help with the program, volunteers are the best recruiters. So if you know people who you think are good and would enjoy volunteering with SHIP, please give them our information, and we're getting training scheduled to start in the spring. So we will have trainings coming up shortly. All righty, let's move on to what was the best part of OEP, Open Enrollment Period 2017. Anybody have any best stories or what you think we did best now that we talked about what we could do better? What was the best? Come on, guys, this is public. Linda, did you? I know your hand's raised. You may have, that may have been for what you said to do better, but did you have a comment?
If you're talking to me, I don't know why it's raised. I'm sorry.
No problem. Just double checking. Thank you. Lonnie said the money we saved people. Yes, our outcomes are definitely one of the best stories and things that we're going to be sharing with countless people. And feel free to use that information as well if you want numbers more specific to your area, to counties, to people. Let me know and I can work on pulling all that data so you can have more specifics on your area to share with your local officials that may want to know, in my county, what are y'all doing? And we can let you all know that stuff. I've become a master manipulator of data. Great. Glenda had sent in a comment, the outcomes most are most definitely the best part, and she'd like to know the amounts of counties that she serves. So, Glenda, I will make a note, and if you wouldn't mind doing me a favor and emailing me that request so I don't forget, I'm happy to pull your data and send you some information. I'm hearing some background noise. Does anybody have anything that they want to talk about? And this could be good, better, or best. Let's open it up to all discussion or something that just really peeved you off during open enrollment.
Hi, Sidney.
Yes.
A really good thing, I mean, one of the best was seeing people be able to get the medicines that they really wanted and not the ones that they could only afford last year. One gentleman nearly cried on his way out because he could finally get the drug that worked best instead of a substitute.
Oh, that's amazing. I didn't even think about that. Being able to take the medication that works for years, but for some reason it was really expensive last year and they had to go to something different, and now they're back on the medication that works the best and are just know in 2018 that they're going to be healthier. That's amazing. Thank you, Sandra. Stephanie Johnson said people coming out trusting the volunteers and staff and helping them with their plans. Definitely. I think every year, and you all can probably attest to this, and I've been to a few enrollment events, and I feel like the turnout in some areas, maybe less than others, but a majority of our areas, every year we get more and more people. And then we have more and more volunteers that step up to the plate and help us at those events. And we're able to serve more people and save people more money. And just, I always say that our program's not the easiest to volunteer for because we have so much information that we kind of overwhelm you with. But our program is one of the most rewarding programs to volunteer for. Just what Sandra said are all of our amazing stories of people leaving with tears in their eyes, with happy tears, and how we can get them to pay for their medications, their food, their electricity, their Christmas presents for their grandkids they haven't been able to purchase in years. So thank you for sharing that. Alice is giving a shout out to ACMS SHIP volunteers, absolutely, who stepped up. And Pat Bryant, you're getting your horn tooted quite a bit for providing computers for enrollment events. I know that's a big partnership that ACMS cherishes, that you're able to help with the technology for open enrollment events to get beneficiaries enrolled. And I do have to give you a big pat on the back, Pat. Oh, wow, that's terrible. You are a tremendous help to the SHIP program during open enrollment with all of that. So I extend Alice's thank you to you specifically for that great help. And then Glenda's thanking the state and local SHIP personnel for staying on top of all the changes and responding to all of our questions in a timely manner. That might be generous when you're talking to me. I try my best to respond in a timely manner, but a lot of you can probably attest that my timely manner is usually delayed. But we do our best, and I know our local staff is very on top of getting everything out to the volunteers as soon as we get it, so you all are in the loop on any trends or issues or anything that's going on in your region. Peggy Ransom said she continues to get callers who need help for paying for insulin inhalers. Many of these callers have extra help. Why are these medications not covered by LIS? I'm not sure if it's not covered by LIS or if it's not covered by the drug plan. So I would have to probably talk to you one-on-one about that, Peggy. When we use Plan Finder and we put in all the medications, if a medication is not covered, that means just the plan doesn't cover it. So we're going to have to look at a new drug plan. Since they have extra help, they should be able to change any time of the year. Now, if it's a new insulin that's come on the market or a new inhaler that's come on the market, a lot of the drug plans may not cover those right away. Especially if they're brand new to the market, they may not have it updated on their formulary for Plan Finder to even show. So if you want to send me an email or give me a call and we can talk about that one-on-one to see if I can help get that situation resolved. All righty. Coming up on about 20 minutes left, so I appreciate all of your input. I'm going to do a couple more slides and then we can come back to our open discussion just in case I hear people logging off, so I want to make sure the people who are staying on get all the information before we end the webinar. This year, for those of you who attended the webinar last year, I did an end-of-the-year webinar survey for you all to fill out, and realizing as we were getting the survey together, it's very hard to remember what we talked about in January in September. So we decided to do a webinar survey per webinar. So after January, we'll send a webinar, February, March. Each individual webinar is going to have a survey for you to have your input, any kind of comments or anything like that you'd like to send us, please do so. You can access the survey in the presentation that I emailed you yesterday, or I'm going to be doing a follow-up email by the end of the day today, kind of a thank you for attending the webinar. I'll reattach all of the documentation to make sure everybody has everything, and I will have the link to the survey in that follow-up email as well. So I encourage all of you to take the survey. The only way we're going to know if this is a worthwhile topic to talk about, if there's anything that needs to be improved on our webinars, is if we get your feedback. So please, if you could, fill out that survey for us. And then I also wanted to remind everyone of next month's webinar, which is going to be Thursday, February 15th, day after Valentine's Day. It's going to be about the new Medicare cards. So there's a lot of information that we need to definitely cover with that. That's going to be presented by Lonnie Hitchcock, our SHIPSMP coordinator. Same time, 10 a.m. to 11:30 a.m. Central Time, 11 a.m. to 12:30 p.m. Eastern Standard Time. And I will be getting a registration out to all of the volunteers here within the next week or so to get signed up for that. And thank you, Mike, for the reminder. I am going to talk about the tip sheet here in a minute. And let's see, we did have another comment from the inbox that last year a volunteer had 2 beneficiaries that selected more expensive plans even after all the explanation. They called me this year and switched to a more cost-friendly plan. It just takes some time. Yes, definitely. All righty, so that is the webinar. Now let me, hey, look, there's my family. I should have had this already pulled up. So our cost tip sheet. This is a kind of a all-in-one, if you need a quick tool to know the cost of anything that we've talked about, here is our cost tip sheet. So it has everything from A, B, C, D, our assistance programs, all that good stuff. So I am going to edit what Linda let me know earlier in the webinar. So I'm going to have this updated, and I will send out this updated copy to you in the follow-up email so you have the correct information. And again, thank you, Linda, for pointing that out to me.
Question.
Yes.
What did Linda point out to you? Where is it on this tip sheet? I'm looking at it now. Which one is it?
It's under Part B, medical insurance. So it's the 1, 2, 3, 4, fourth box down on the first page where it's bold.
Got it. Got it.
And then it said maybe higher than 104.90. I'm going to change that to the 134.
Gotcha. Thank you.
No problem. So as you can see, these are all the numbers that we've already talked about, so I'm not going to reiterate them necessarily. And here's our IRMA cost. The last page we will have updated, and I will send it again when we get our new LIS and LIS meaning low income subsidy extra help, and our MSP, our Medicare Savings Program, the QMB, SLMB, and QI1 numbers. I'll have this tip sheet updated for you again for our March webinar. So there's that one. And then I also found a CMS, Centers for Medicare and Medicaid Services publication, that is very similar to our cost tip sheet, but it's an official CMS document so I thought I would share that with you as well, of how we got these numbers. So not saying you don't think that we're credible, but just so you know where we're getting our numbers from, kind of citing our sources, so to speak. So we have our Part A, B. I'm going through this fast, and I apologize for that, but you all have the resources. Here's our IRMA increases, B and D premiums, IRMAs for D, and you all have that for your resources as well. And Peggy also mentioned that NCOA, the National Council on Aging, also has similar tip sheets. Peggy, if you wouldn't mind, if you have that handy, if you could email that to me, but I'll do some research and get that cost tip or that tip sheet as well out to the group in my follow-up email. That way you have, figure more resources are better than less, right? Let's see. We also had a comment. Yes, on the webinar flyer that I sent to everyone in the holiday card, for those of you who received the holiday card from me, I did have an error on the June webinar date. The June webinar date is actually Thursday, June 17th, which is the third Thursday in June. And, oh, I'm sorry, no, wrong. Thinking it's the other way around. It's June 21st, which is a Thursday. The 17th is a Sunday. We're not having a webinar on a Sunday. I apologize for that. The webinar is going to be Thursday, June 21st, and not on Sunday the 17th. So we'll get more information, and I've updated that flyer and sent it out as well. So third Thursday of every month. Thank you, Mike, for reminding me about that. Alice mentioned, did you mention some breathing medicines are covered under Part B rather than D? So we do have some medications for breathing treatments that are put directly into durable medical equipment, so like nebulizers and things like that. If there's medication that goes directly into durable medical equipment, that is covered under your medical insurance and not your drug plan. The same thing goes for insulins that go in insulin pumps. Any medication into durable medical equipment is covered under Medicare Part B. Thank you, Alice. That's a great question. All righty. Well, that is everything that I had for the webinar today. So I appreciate everybody joining today, and I'm going to have the last call for questions before I end the recording. All righty, and I'm going to stop the recording. Thank you all so much again for participating this month.